right? I mean,
Right, it's, it's not an FDA-approved form of contraception,
Yeah.
so we know that, especially when we're talking to young people, we really talk about contraception a lot, and sometimes it will be, my partners are always cis women, or a trans man, but, life is busy and changes all the time, and particularly for our youth population, so we usually recommend contraception, and if it's not condoms, there's Depo, there's Nexplanon, there's progesterone-based contraception, IUDs. I think we're talking about it much more than we might have before with this recognition of just more awareness about it, unintended pregnancy, and
yeah, there's one other thing I'm wondering if you guys might ask about, and it has to do with how many sexual partners he's had, and his risk, therefore, if in 6 months he's had over 10 partners. Any thoughts?
PrEP?
Yeah, awesome. That would be a great thing to talk to him about. And it might not be, we're going to prescribe you at this visit where you're here for screening. It may just be like, I want to give you some information about your risks. And we can talk about it today, or we can talk about it when you come back, if you want to. And at very least, if you're going to continue having partners to this degree, let's see each other every few months and just do some screening.
And then special considerations for PrEP. So
yes, we'll do that. And then also immunizations. Anyone want to jump on that one? Just thinking about.
Someone said HPV vaccine.
Okay. And we're doing, hepatitis A. We're
You're right. I think the twin Rex would be
Yeah.
recommended if he wasn't vaccinated, just MSN related risks. But yeah, did you want to chat about
Sure.
the public?
So special considerations for PAP. So one is, and has anyone have experience with pelvics with trans men before? Is that part of anyone's practice? Maybe you. Yeah. Yeah. So the on testosterone, and I'm not sure exactly how long it takes, but the vaginal wall gets pretty atrophic, and so it's not uncommon to get inadequate or insufficient cells. So there's one way is, so hence when we're screening and before we start T, it's always great to have that conversation. If a man has never had a PAP, like we're going to get a much better sample before you start. It'll give you a couple of years under your belt. So sometimes that's it. Sometimes it's a little bit, there's other things going on for them, but I always think of that as a provider. And then special considerations are a little bit more, one is if they don't use their, one is to asking them how they refer to their parts, which is really helpful, and some people look at you blankly and so you just proceed, but I do try to ask that. The other is the reminder of if the part is there, screen it, even if you don't like having the fact that you have a cervix, you do, and we do age-appropriate screening, and that reminder. And then the other is, so a couple things you can do with the broom is trim it and make it more narrow, use a small speculum, be a little more vigorous with collection, although that can cause bleeding. And then sometimes if it's repeated insufficient cells, we use topical estrogen. And we do that for a couple of weeks before, and that really improves collection. The other issue is sometimes that somebody doesn't want a PAP and refuses, and so I will meet people in their 30s and 40s that have never had one. And so what we have, we should get this video, but what we've started to do in the last probably couple of months is self-collection. So you can either do a blind swab, the provider can do it, or the patient can do it themselves for HPV, and it's a vaginal PAP, and then it gets sent in our system, but we're now all in the same system. We're at the Community Health Center, but we use UVM, it gets sent to Mayo for HPV testing. And there's a nice video from the Fenway that shows guys how to self-collect that I show, and then I step out of the room, and I give them a brush to use, this cyto brush.
Can you kind of walk through your conversation that you have with the individual?
Sure.
And if they're a little more resistant, and how do you, I guess, encourage but not be forceful? I don't know. Just
Yeah.
I mean, I think part of it is we have an ongoing relationship. So sometimes starting, I did this the other day. I saw two 21-year-olds. Hey, if you have a cervix, let me just tell you a little bit about cervical cancer screening, and take out a speculum and show it, and just sort of run the options. We could do this today, or we could do this when you come back. And we have the benefit of we're doing hormones, so we're going to see them every couple of months. And then every time they come back, have you thought about it yet? I mean, sometimes it's 2 years. The fact the self-collecting has made an enormous difference. There was a study done that are people familiar with the Fenway? It's a LGBTQ health center in Boston, but they did a study of were the was the collection technique adequate compared to those who didn't self-collect. And so it's not exactly the same, but it's something. And so first, it's certainly compared to someone who's going to decline and won't do one at all. And I would say that those 3 options now of either just doing it with us or doing the blind swab without the speculum or then self-collecting, I think will continue to improve our care.
Also, I can't really think of a situation where it's urgent to get the PAP. So I think even just having that discussion is huge, and then like empowering them with the resources to, like if you're sensing this is a lot for them to take on right now, they don't know me, this is not going super smooth. Because you'll also have the people who are like, yeah, let's get it done, I don't want to have to come back, and it's not a concern for them. Then you just say like, do you have somebody that you could see? Can I give you some information? And it doesn't have to be like a huge, hurdle to accomplish it.
And then the other thing that we do, but that's a perfect, there's a trans affirmative, public service statement. But I think, just reminding people, letting them know, and then the other considerations about in terms of doing it rather than just collection or technical issues are, this is a population who has a higher incidence of sexual trauma, and so talking about, which everyone here who does these is doing anyhow, anything we need to know. This isn't, an emergency, appendectomy. If any time during this process you want us to stop, we will. And you can, think about it. We'll keep asking you about it like that. So we just, talked about a lot about trans men. I will, many trans men have, if they have one surgery, it's top surgery or chest reconstruction. It is a modified, but not a complete bilateral mastectomy, so there is some residual breast tissue. And hopefully there's been some discussion with their breast surgeon, if they've had top surgery, about the best way to screen them. Most do not require mammography when they are of age, but chest wall exams. And then unless they are higher risk for some other reason, family history, mutation, etc. So that's trans men. Trans women, trans women, even if they've had gender confirmation surgery, still have residual, or they still have their prostate. It is not removed during gender confirmation surgery. And so then we would do age-appropriate prostate cancer screening. There is no evidence that there is a higher risk of prostate cancer with feminizing hormones, and presumably possibly less because of the blocking of testosterone. In terms of breast cancer screening, the newer recommendations, and again, there's not anything very clear, but there's a lot of discussion about the best way to screen transgender women in terms of breast cancer. I think earlier and over the last decade or two, there's this thought, like with cis women, we start, you've had, 40 years plus of estrogen exposure before we start doing screening. But I think some of the concern is there was a Dutch study that suggested that trans women on estrogen are having earlier higher incidences of breast cancer than cis men, and that we should be screening them probably if they are on hormones, when we begin screening cis women, because we just don't know and they are at risk. And then all our patients in primary care, we talk, because of that, they are a higher risk group of substance abuse disorders and mood and anxiety disorders and sexually transmitted infections. We do that screening as well. We weren't planning on discussing sort of the lab monitoring, but we do definitely follow metabolic labs, lipids and glucose. And then special consideration colon cancer screening. This is a big issue around privacy, because there are a number of people who are not out in their community. Many would not like anybody to know that they've transitioned. And so colon cancer screening involves typically going to your local hospital, having conscious sedation and having people see your genitals. And, you know, I know someone that works, even if it's people, it's you know, even if they work, I know someone in medical records, I know someone who works at the lab, and I would never say to someone, oh, don't worry, nobody in, you know, because who knows, right? So people will travel, you know, we have people who go down to Dartmouth, across the lake, either way, just so that they are in a place where people don't know them. And occasionally, you know, we'll make a call in advance, someone will ask, could you just let them know in the meeting before. We also take advantage of the fact that there is other screening besides colonoscopy, in terms of Hemocult and Cologuard, and those are good options for people too. But again, it's this just reminder to all of us that there is that there's a lot of anxiety and concern and sometimes fear about being seen and outed and exposed. So this is really kind of a general hospital. We wanted to just make sure we included some of the issues that come up in an inpatient setting, and we didn't sort of discuss. We didn't really ask before we started who's here and what part of the hospital you represent. But I guess the horse has left the barn at this point. We will just talk. You know, if anybody works in the inpatient setting, hopefully this will have some relevance. So this is a healthy transgender woman who is admitted to orthopedics with an opiate tibial shaft fracture and presumably will need surgery. Her sister is there to support, but using her birth name, John, and he, him pronouns. So these are just some questions to think about. You know, how can you affirm this patient and support them with their family member who is not?
Well, I think you're not going to change the family member, but you can model like she, her,
Yeah.
you know, calling her Carla.
Yeah, exactly. I mean, I think that's what we do. They're our patient, and we're just going to do what we need to support them. Rooming assignment, you know, I can just, we have another case that we want to get to, so I won't spend a lot of time on that. But, you know, at UVM now, there's the Miller building, so, you know, ideally a patient would have their own room. You know, if not, the LGBTQ legal organizations in our country recommend having people assigned a room that reflects their gender identity. Someone the other day brought up, well, what if there's a, you know, elderly, you know, person in the next room who is feeling threatened and uncomfortable? You know, there's no real answer for any of these. There's just thinking about them, talking about them, and how to make everybody feel as comfortable and safe as possible. So certainly a private room is best. Bathing, toileting. This comes up with our nursing staff when we have these discussions. Sort of, we meet someone in a setting like this, they're going to be non-weight bearing, they're going to need help with toileting or bathing, and we don't necessarily know anything about their anatomy, and so how would we have that discussion? And this is really based on people's experiences or thoughts. Again, there is no right answer to any of this.
Maybe could you just ask, like,
Yeah.
these are the options. I don't know what your anatomy is. Would you like a urinal or would you prefer a bed pan?
Yeah.
That's great. Straightforward is good.
Yeah.
Or starting with tell me about yourself so that I can best care for you.
Yeah, and then you could even do like it looks like we're gonna need to support you in being able to go to the bathroom because we can't walk yet. So how do you think we could navigate that? And they may just tell you right up what they would need, and if not, then I would just say these are our options, like which would be best for you. And as long as you're saying these things like respectfully, then they'll be like, thank you for giving me choices. Any other thoughts about that or concerns?
Should the estradiol be discontinued?
Yeah,
That's my
So the question is maybe, maybe not, you know? So I think that the point of this is that there's a lot of times when people get into the hospital and their hormones are just stopped. This comes up on psychiatric admissions, and really I think the point is, without sort of exploring the, you know, the ins and outs, is maybe, maybe not. It's a discussion with the patient about risk, the orthopedic surgeon, possibly the hematologist, like that. And that brings us to, we thought we had one evidence-based slide. We thought we'd bring, there's more and more evidence-based medicine available to make these decisions, but this was a big study, a Kaiser study at several sites around the United States that was published in last summer. And basically, it just said, which I don't think is a big surprise, that there is a higher risk of thrombotic event for trans women on estrogen. And anything that we can do as providers to mitigate that risk is what we work on, and just letting people know that that risk exists, however low. All right. So I think we have time to do this. I think this is a good problem solving, because this is actually something that happened with a few details that changed, and I thought it was it's just really instructive to think about why it happened, how it happened, and potential consequences for what happened. So trans man presents to a local urgent care with 2 days of lower abdominal pain, looked really good, afebrile, normal labs, with the exception of a positive urine micro for lots of white blood cells. The patient was very clear. This was actually one of my patients. He told the provider he was a trans man, and then was treated with 10 days of broad spectrum antibiotics. So just some thoughts about anything.
PID.
Well, no, we don't know what the problem is, right?
There was no exam.
Right, and so I think, what happened, I think, possibly what happened was that the provider didn't know what transgender man meant. There was nothing, the person felt comfortable. It wasn't, I wasn't offered care. The person seemed repelled by what I said, which we definitely hear sometimes, occasionally. It was more that perhaps the person didn't know what my anatomy was. I didn't clarify it, and neither did they. So either there was the assumption of, I know what a transgender man is, meaning I know what that means about anatomy, or I don't know but I don't want to ask, or maybe didn't hear, but was treated as if he had a much longer urethra than he had, right? So that was one thing. The other was, and so, okay, he had 10 days of broad spectrum antibiotics, not the end of the world necessarily, but what if this was we brought it up before, a young trans man who had an ectopic pregnancy and came in with, normally any biological female comes into an urgent care, we do a urine pregnancy test with the urinalysis. So that would have been missed. I mean, extraordinarily unlikely, but certainly worth bringing up. Again, that one moment of someone didn't know something, maybe felt, I'm just making this up also for us to sort of think about it, maybe felt uncomfortable asking, but had some clinical consequences.
So I'm a palliative care doc, so I'm often having to have discussions with people and suss out like how ready are they for it. So I'm just reminded of that, one technique we use is kind of an ask, tell, ask. Like, would it be okay if I asked you a couple questions so I could better take care of you? And so that kind of, because it's hard to ask something that you're uncomfortable with.
Yeah.
And I think, especially in modern medicine, when there's 100 tests you can do instead of asking a question,
Yeah.
like just to also remind people, like you have a team, right? So you could go over and say, Anna, I gotta ask this guy a question. I don't know how to say it. Can I practice it? Or if I say this, is it okay? Like just to remind people about, we don't always know how to say it or what to do it, and just to remember to check in with your team or not be afraid to ask for help, or maybe you want somebody else to do the questioning, whatever it is, just to, because we're not taught to be comfortable with our discomfort.
Absolutely.
We have a million ways to avoid it. So, but then once you do it and you've got a chance to practice it or gotten through an uncomfortable encounter, then build your confidence a little bit for the next time.
Yeah.
Good, too bad you don't have we couldn't role play.
Agreed, and I think in this case, we're also working with our patients on telling them and advocate for yourself, because it's you. So I think he thought I was. I told him I was a trans man, and then I will just really briefly, a nice counter story to this of someone we know, a trans man, Rutland Urgent Care, walked in and said, I'm a trans man, I have a UTI, these are my symptoms. He said, the nurse practitioner said, okay, well, you're a man with a short urethra, so we'll give you 3 days of antibiotics, as opposed to a man with a long urethra where we would treat with blah, blah, blah. So it sounds like this person felt really comfortable, didn't miss a beat, had language that was affirmative, the patient advocated for himself. It was like a win-win. So I just like to share that.
So we have like just a very few minutes left, but if anybody had like a burning question or something that we didn't clarify well in the talk, this is the time.
I guess one of the important things is documentation and identifying the correct pronouns with that individual. And is it appropriate to say, let's say John presents to the ED and he's a trans man. Is that okay to do? And do you recommend that or not recommend it?
Recommend documenting trans man.
Yeah.
Yeah, I recommend saying, you know, when I write this note up, I do need to use some, you know, designators. And usually what I would write is a 28-year-old male or 28-year-old trans male, like what would feel comfortable to you. And not that you're going to be able to do that in every situation, but if you think of it, and it would be good to include them, because it has happened at UVM that there have been grievances made about, I got my records and there were a lot of pronouns that were used, there were the wrong names, you guys didn't respect me, that kind of thing, and it's become a big kind of
And so that you guys know in Epic, they have gender affirming, so there's this whole thing with Epic, and so when you get, I think, Krista, there's some stuff in Porter, so about it, but there, actually you can choose, instead of there's like the legal name, but actually the name flows. So one of the things with Epic is a lot of times names flow right into notes, they just auto-populate. So now the auto-populate will be the name of choice, and also you can, there's ability within the registration process to choose preferred gender, including non-binary.
And sex assigned at birth, yeah.
Yeah,
And
it
so-
needs to be that way, so I'd go through all this trouble of writing this
Be
beautiful
perfect,
note.
yeah.
This is John, transgender man, has not had surgery, preferred hormones, and then as I'm doing the note and pre-populating, it would change everything to another hormone.